Right, so thanks everybody for making it promptly back. And now we're in session 2 on lung diseases. And I'm Omar Osmani from Imperial College London. I'm a professor of respiratory medicine there. And my co-chair for this session is...
Regina Schallies from Kiel University in Germany. Welcome back.
So Regina, so far, session number 2, how are things in your perspective with respect to what you've learned today?
Well, we had a great start with the nasal pre-conference workshop, where we discussed a lot about how actually our in vitro methods and all the different characterization methods relate to an in vivo effect. So I'm very curious to hear now how that translates to the current session.
Because you nasal people were saying that's more important than inhaled drug delivery, weren't you? So we'll see what this session holds. So without further ado, we're going to be talking about device, cell biology, and airway disease. And we planned the program, didn't we, Regina, in a way that gives you a breadth of things. Obviously, we can't get away from COVID, and there's some important research that you'll be hearing about. So it gives me great pleasure to invite Professor Chantal Darquenne, who's flown over from San Diego. And Chantal, you again have such a solid biography, so please forgive me if I miss all the important pieces out, but you are associate editor of the ISAN textbook of Aerosol medicine. Your research is focusing on inhaled drug delivery. You've connected with a very big multidisciplinary team over the years of scientists that you've worked with. You were or are past president of the International Society of Aerosols in Medicine, and you've had major funding awards, and just to name one, through the US Environmental Protection Agency. So if I can invite you to the podium to give us a talk and tell us about airway disease on drug deposition in the lung. Chantal.
Thank you very much, Omar, for this kind introduction. And so when Omar asked me to talk about the effect of airway disease on drug deposition in the lung, and I agreed to do this talk, he said, but you only have 20 minutes to talk about it. So that's going to be the biggest challenge for this talk. You could spend a whole day talking about it. So the idea here that I want to present to you, first I have no this financial disclosure, it's that I would try to give you an overview of what the main points to consider when you look at drug deposition in airway disease. And I don't have to convince this audience that drug delivery by aerosol inhalation is a pretty well-established delivery route, and it's been used mainly for maintenance therapy in asthma and COPD, but more recently also used more for topical delivery in less common diseases, including CF or pulmonary arterial hypertension. The nice advantage of aerosol inhalation is that you can require only a very small dose to elicit a therapeutic effect, and that effect can be relatively rapid, and also you can minimize systemic effects when your target organ is the lung. Of course, this effectiveness, it's linked to where in the lung your aerosol that you just inhale end up depositing. So when you have an inhalation device, and we heard a lot about that in the previous session, the first thing that you're concerned about is where the drug that just was aerosolized end up in the lung. And there were 3 main regions where the drugs will deposit: in the mouth and throat by oral inhalation, and then of course in the conducting airways, or much deeper in the lung periphery of the lung. And of course then you have a whole set of events that have to occur. And one is the drug dissolution, which is competing with the clearance mechanism at the same time that they are just depositing either in the conducting airways or in the alveolar region of the lung. And then the next process has to be the absorption to the lung tissue and eventually transfer into the systemic circulation, and then you have this loop that is closed. So it's a big process. And I'm only going to focus on this talk to that number 1, which is the drug and droplet deposition. So when you inhale particles, there are 3 main mechanisms by which these particles will deposit in the lung. And in terms of pharmaceutical aerosols, really the 2 main mechanisms that we are dealing with is inertial impaction, that is mainly affecting large particles where they just impact on airway surfaces because they can't follow the sudden change in the direction of the flow that you inhale. So it's the main mechanism of deposition in the throat. And then gravitational sedimentation, which affects particles of 1 micron and up, and it's basically the settling of these particles in the airspace. So this mechanism is more prominent in the deeper part of the lung, where you have smaller velocity of the flow in the airways and much smaller size of your airway space. So the distance to be covered before it settles, it's much less. And as I'm a mechanical engineer by training, I like to look at models to try to understand things. And you're probably very familiar with the Weibull model, which is a simplified description, but accurate enough of the lung generation that start with the trachea once you pass the oral path. And do I have, yeah. There is about 14 to 16 bifurcating airways of conducting airways, and then you reach the lung periphery of the lung, which is the most surface area is contained in that distal part of the lung. But in terms of aerosol transport, one aspect of this complex geometry is that if you look at the total cross-section as you go deeper in the lung from the trachea down to the lung periphery, and for each generation, you sum the total of all the cross-section of the airways belonging to that generation, you end up with a very drastic increase in the total cross-section as you penetrate deeper and deeper in the lung. And if you breathe in at a constant flow rate, the consequence of that is the velocity in these airways will drastically decrease as the product of the two equal your flow rate that's constant. Knowing, and this is just an example for a 0.5 liter per second inhalation flow. What does that mean is that in each generation, you can now estimate based on this model, the time that a particle will need to travel through one airway in that given generation. And because the velocity decreases a lot when you get to the lung periphery, the residence time, even though your airways become smaller, increase in a significant manner. What does that mean for aerosol transport? Well, in terms of deposition mechanism, impaction is a velocity-dependent mechanism. And as such, that's the mechanism that will really help depositing your particles in the first generation of the lung or the conducting airways when you have sufficient velocity to give enough inertia to your particles. Sedimentation, which is the other main mechanism of deposition for pharmaceutical aerosols, is a time-dependent mechanism. The longer time a particle can reside in an airway, the more they can settle, and the higher the chance is that this particle will deposit. So that's a mechanism that's really efficient in the small airways and in the lung periphery. And if you look at this, and these are very old data, but kind of gold standard in the field, was one of the first complete set of data that shows you the effect of particle size for a constant flow rate, in this case, 0.5 liter per second, and give you the total deposition. If you measure the number of particles you breathe in, how many comes out, the rest is retained in the lung. And you can see that for the aerosol that we're concerned with for pharmaceutical, they start just past that minimum where particles are too small to really deposit by any deposition mechanism. But once you increase that particle size, because of increased velocity, because of increased size, the settling of these particles increase and you increase deposition. When you get to the very large particle, you also have an increase of the inertia of the particle that causes particle to deposit. But that doesn't tell you anything about where in the lung these particles actually deposit. So the next step, and something that you're probably most familiar with, is gamma scintigraphy studies that kind of give you an idea of where particles deposit in the lung. And this is just the use of radio-labeled particles. And you're more familiar with this typical type of pattern where you can see deposition of particles for whatever application you might have. These are typically include also in these studies a ventilation scan or a transmission scan so that you can actually determine the boundaries of the lung that you're looking at. And by analogy, I put just here a cast of the human lung, because I would like you to keep in mind that when you look at these measures and you get central versus over peripheral deposition data, to remind you that the central mainly include the large and medium-sized airways, but you don't have all these small airways that are also sometimes talk about central before you look at the lung periphery. Those are not reported in that central region. But at the same time, in the central region, because you have a planar image, you also have information of deposition that occur in the lung periphery because of that complex lung geometry that the lung is. So if you take these measurements now, not just immediately following aerosol exposure, but also as a function of time, you can start delimitate deposition not only as a total deposition in the intrathoracic lung, but also in the alveolar or extrathoracic region. And typically what's done is that you retake an image 24 hours after aerosol exposure, which is commonly assumed that's the time frame it takes for particles that deposit in the conducting airways to be completely cleared. So the difference between the two give you what remains in the lung periphery, and you obviously also correct for decay in your radiolabel material. And so if you do so, you can now start getting information not only on the total deposition, but also on where, at a very coarse level in the lung it deposits, meaning the gas exchange region or alveolar region of the lung or the conducting airways where mucociliary clearance occurs. And you can see again the effect of particle size on these effects. Now, lung disease will affect where particle deposit in the lung, but even before even talking about lung disease, a study we did in our group and also in collaboration with Bill Bennett at University of North Carolina, we just look at the effect of inhaling the aerosol while you're seated or you just supine in lying down. What's the difference in deposition? And this is again the typical transmission scan to figure out where the lung boundaries are in your images. And then these are depositions that were made with an aerosol that was about 5 micron as a mean MMAD. And you can see different patterns that when you make these measurements at different time, which we did here, where we normalize deposition at the end of aerosol exposure being 1, and we measured over these different 6 subjects we had, the retention of how much is retained in the lung as time progressed, you can kind of arbitrarily distinguish between large, intermediate airways, small airways, and the lung periphery by doing your measurements the next day. And the data we obtained showed that in the seated posture, most of the particles, even for 5 microns, that deposited in the lung, intrathoracic, were doing so in the lung periphery. And that if you wanted to target the small airways, most of them, you had a much more efficient way to do so if you were into a supine position, sorry. But before your particles can actually deposit in the lung, the biggest mechanical barrier to lung deposition is deposition in the extrathoracic oral airway. It's a major source of not only intersubject variability, but also intrasubject variability. And this intersubject variability can be assessed in part by modeling, and our group has also done using these different models. You can appreciate from this slides how much variable in subjects that upper airway geometry look. And we had 4 COPD patients in these data sets and 7 healthy control, which there was no major difference between COPD and healthy as suspected in at least the geometry, because you would expect the alteration in airway structure to be much more deep in the lung. But using this model, my postdoctoral fellow, Azadeh Borajani, simulate for 2 different flow conditions deposition in or filtering in the oral airway, extrathoracic airway. And typically for this type of simulation, you plot these data as a function of a parameter called the impaction parameter, which is the product of the flow rate and the square of the particle size. Because in this region of the lung, the main mechanism of deposition is inertia. So this has been used traditionally as one of the factors you plot data against. And you can see, the biggest thing you can see, it's this huge intersubject variability. The gray symbols gives you a low flow rate inhalation of 18 liter per minute or resting kind of flow rate. And the dark black symbols for all these subjects give you a flow rate that's basically kind of in the middle of that 30 to 60 liter per minute that's usually recommended for use with DPIs. So what does this type of data means? If you considered, or first before that, I wanted to show you too that these data match the blue line. It's the best fit of all our in silico prediction that we plot against that red line. That is an equation that was derived from in vivo data back in the late 80s. And I hope you will agree with me that as a best fit average curve, our data sets was very representative of what was published before. So in terms of pharmaceutical aerosols, typically you try to get an aerosol size distribution that's between 1 and 5 microns. And if you use a nebulizer, and which could be breathed in as referred by our data that were obtained with 18 liter per minute or the gray symbols. And if you look at the data from 1 to 5 microns, depending on the subject, you can appreciate that when you get beyond 3 microns, some of these subjects will have more than half of the inhaled dose filtered by the oral airway that will never reach the intrathoracic region of the lung. At the other end, the same particle size with the same flow rate of some other subjects will have minimal deposition in the oral airway, which really show the complexity of predicting a dose efficacy in subject because at such large variability in deposition. If you look at a case with our 45 liter per minute prediction, which would be more like what you would expect with a DPI inhalation flow rate, you can see again here the 1, 2, 3, 4, and 5 micron of that ideal aerosol size distribution of a nebulizer. And you can see now that for 5 microns, some of these particles will not even reach the intrathoracic region of the lung, completely filtered by the oral airway with a potential of side effects that you usually want to minimize. So this is all the variability before we even put airway disease in the mix. So I looked at the literature and what studies that have looked in a controlled fashion at deposition in patients with lung disease, and there is not that many controlled studies out there. One of them was for 25 years ago now by Chung Kim at the EPA in North Carolina, where they did a very controlled study where they used 1 micron particles with a very controlled breathing pattern and different groups of subjects from normals to smokers with small airway disease, asthmatic, and COPD. And they show that in all these groups, when you compare it to deposition in normal subjects, you increase deposition in the lung. Now, in this data too, if you try to link deposition fraction to lung function as predicted by the FEV1 measurements, you can see that the higher deposition, it's not really because it's COPD versus asthma, it's because in this study, the COPD population they use have lower lung function than the asthmatic, but they show kind of a trend of a relationship between deposition fraction and lung prediction. Now, when you look at these data that are all kind of global measurements, you still don't know where in the lung these particles deposit. And you cannot assume that it's a uniform deposition, especially with gamma scintigraphy data showing very often that there is very large heterogeneity in deposition when you have lung disease involved. And this is just one example taken from Beth Laube chapter in the ISAM textbook of aerosol medicine, where she present data for an asthmatic subject, severe asthma with a FEV1 of 36% predicted with relatively small particles, 1 micron or extra fine particles. And you can really appreciate from these type of images that while she could reproduce a very uniform distribution of deposition in a healthy subjects. When you get heterogeneous distribution of construction of these airways, you start creating very heterogeneous deposition patterns. In another study by De Backer at the University of Antwerp in Belgium, they look at three different groups of subjects, healthy, asthmatic, and COPD, where they use 4 puffs of an ICS-LABA combo, very fine particles with an MMAD of about 1.3 micron, and they ask for a slow inhalation followed by a breath hold. And they look at that central to peripheral deposition ratio, which I talked about in a few slides before this. And so if you had no hotspot in the large and intermediate airways that are mainly contained in the central region, you would tend to have more like a ratio that's equal to 1. The higher the ratio gets, the more deposition occurs in the central region with hotspot at bifurcation typically or in constricted airways. And you can see that, and I plot here, I wrote down under this graph what was the FEV1 of the groups they studied. And again, you can see that once you get to poor lung function, you get a widespread and a very heterogeneous deposition within patients even of the same type of disease, which makes delivering aerosol to the lung of patient kind of a challenge because you may have a completely different deposition pattern and then it's a different response to a drug. So to try to understand beyond these images that are still quite coarse in resolution, one way to look at deposition at the airway level is to go to in silico modeling. And in silico modeling has been a major focus not only for pharmaceutical health research, but also in environmental toxicology for decades. It allows you to complement either in vitro or inhalation studies to also try to make a link between data you have in preclinical studies in animals to humans. But even though there have been a lot of recent development and improvement in silico modeling, I still believe that to this date, the challenge of predicting the deposition of inhaled aerosol under disease condition is still largely unmet with in silico modeling. We have made improvement over the years, but I don't think we're quite there. So the type of modeling that gives you that per airway information is usually done with computational fluid dynamics that kind of a complex technique that was a little bit presented earlier today for the MPDI technology development. It allows you to give you pictures of where, based on different conditions, particle deposit in the lung, and you can kind of look at hotspot and analyze the data at a very coarse, fine level that may be even too much in practical conditions, but because it's extensively expensive in terms of computation need to do this type of simulation, it's usually only focused on a very small region of the lung, like showing here, like the first few generation of airways. And because of that, you cannot really model a full breath of an inhalation of an aerosol. And also, these type of simulation are very sensitive to what kind of flow comes out at each of these outlets. If you have that distribution not representative of what's happening, you're going to have data that are not meaningful. So one approach to try to get around this problem has been the functional respiratory imaging technique that's been developed by Jan de Backer and kind of commercialized with Fluida, where they use CT-based lung models of the airways that are actually visible on CT scans. And then they connect these flow distribution at the boundary here based on 2 CT images of the lung at 2 different lung volumes so that they can determine the global distribution of the flow between these different regions of the lung. And by adjusting their model so that it represents the proper increase in lobar volume between the beginning and end of their inspiration, they can come up with an estimate of aerosol deposition in the lung. One of the caveats of this technique, though, is that once the particle goes beyond the model, they assume that everything deposits in the periphery of the lung. You still don't know where, and you don't know if anything of this particle would be breathed out because it's only an inhalation problem. So in my lab, what we have trying to do is to try to do a full breath deposition. Oh, before doing that, this is the kind of data that you then obtain. And this is a very recent study that was published last year, where they look at the effect of different DPIs and at the same flow rate and try to show differences in the delivery in the different region of the lung. So in our lab, what we're trying to do is to use, again, CT-based model of the first generation of airways, but link every of these outlets to a one-dimensional simplified model to be able to simulate a full breath of aerosol inhalation. And this model, the multipass particle deposition model that we use, is deterministic. It's used right now for steady state conditions, and it can provide total regional, lobar, or even airway level specific information, which we recently improved to include a more realistic alveolar mixing of this aerosol being breathed in, and also allow to do more than one breath simulation. And by doing this multi-scale modeling, what we did, so we used a model, again, very similar to the approach used by Jan de Backer of a CT-based model. Part of it was used in a 3D expensive computational simulation, and each outlet of that model was linked to one of these 1D MPPD subtree. Then we also had two measurements of the lung volume that we segmented at the lobar level to see the flow distribution at each level. And we modeled experiments that we actually perform on the same subject in the same position that they were when they were, the CT scan were collected on these patients. We monitor not only the aerosol inhalation and exhalation, but also their flow when they were performing the experiment. And we put those data as an input directly in the model, and we see how much deposition the model would predict based on what the experiment would allow us to do. And these are the prediction in that first model we did, which hopefully you'll agree with me, it's a pretty nice agreement between the data. Like I told my team, we did n equal 1, it works. I think we should stop there and publish, not try another subjects, because I'm not sure we're going to be that lucky again. But we were able, by importing enough of these information on subject-specific information, to actually match pretty well our prediction to experimental data. So in summary, as you all know, drug inhalation is a mainstay in the management of respiratory disease. And hopefully I convince you a little bit that its success not only depends on the pharmacology of the drugs being inhaled, but also on the site and extent of deposition in the lung. And so it's something worthwhile investigating. Such deposition is tightly related to the physical property of the inhaled aerosol, but also of the characteristic of the patient, with the throat being the major factor or the major source of variability in lung deposition. For people that have healthy or mildly diseased lung, you can still achieve reasonably uniform deposition of pharmaceutical aerosol with optimal inhalation flow rate and particle size. But that's no longer the case with people with more severe obstructive airway disease that have very high heterogeneous deposition pattern in the lung. So when you look at a locally acting inhaled medicine, a measure that reflects not only the lung deposited dose versus emitted dose from aerosol devices, but also deposition pattern, may be a much more predictive factor for therapeutic performance than the delivered or emitted dose from your nebulizers or DPI or other aerosol air generator. So in terms of aerosol modeling and inhaling the drug, I think that we still have a long way to go. These data that I show you were done in healthy subjects. It's a completely different beast when you try to put disease in there. And so we're working right now on adding lung mechanics to our models so that we can actually vary the structure and the distribution of flow in the airways beyond what's visible on the CT scan. And if you can do that, hopefully the holy grail would be that you can maybe use this modeling to assist for the selection of patients to include in clinical trials based on their subject-specific characteristics. And if you can do that, you can hopefully ultimately reduce the cost of these clinical trials due both to a more efficient drug use, but also to reduce the variability in your clinical outcome by properly selecting the patients. Conversely, you can use in silico prediction for existing clinical trials outcome to provide detailed information on these inhaled aerosol, and that can have a positive or an advantage, especially when you have clinical trials that have didn't prove what their intent was, and so you can maybe help indicate why your clinical trial failed. So that may be another use of in silico modeling, and I've gone very beyond my time, so I'll stop here, but I would like to acknowledge a lot of the people over the years that have helped me. It's not a one-person work, the funding, and I'll finish with shameless advertising for the next ISM Congress next August. Thank you very much.
Chantal, that was comprehensive, and you walked us through very nicely aspects of your research, contextualizing what we'd asked you to do is talk about health and disease. Alas, we only have time for one question. So, does anybody have a question they wanted to ask? If not, there are several that I can choose from that have just come in. So, yeah.
If you want to ask a question, please raise your hand quite high so that the microphone guys can actually see you, and then they will run towards you.
Okay, so there are lots of similarities to what was being discussed this morning in the nasal session in terms of in silico, in modeling, in understanding absorption. So can I ask you, what is the optimal regional site for drug targeting?
Depends what you want to treat, right? If you want something that gets into the systemic circulation, you want to reach along periphery. If you want to treat asthma, you want to stay in the small airways and maybe medium-sized airways. So depending on what's your outcome, your endpoint, it's going to depend. One size doesn't fit all.
Super. And what strikes me from your presentation is this area is so important, and understanding the dynamic change in the oropharynx as somebody inhales rather than a static approach to what we use at the moment.
It would be, yeah. And the other thing too is you move your tongue one time and you take the same drugs, you're going to filter more or less particles.
And some of that data third question, some of that data makes me think that, so COPD patients lose musculature and then they have problems with dentition and then seal, and all of those factors will affect, and probably that's why you get so much in the throat.
Yeah, so the finer the particles, the easier it's going to be to reach the intrathoracic lungs. That's one of the messages.
Perfect, that links with what Federico was telling us about. On that note, thank you very much, Chantal.